Right, good morning, everyone. It is wonderful to see everyone both in person when we can and virtually. I am delighted once again to introduce Dr. Roger Härtl, who is a professor of neurosurgery and spinal surgery here at Cornell. Dr. Härtl received his medical degree at Ludwig Maximilians University in Germany, where he then completed his postdoc actually at the Brain Tumor Foundation here at Cornell. He went to Allegheny in Pittsburgh for an intern year and then was drawn back to Cornell for his residency. After that, he made his way all the way to Phoenix, where he completed his spine fellowship at the Barrow. But by this time, he was already a New Yorker through and through, and he came back to join the neurosurgery faculty here at Cornell and has led the development of our spine center. Dr. Härtl recently spoke to our group about his tremendous success and experience driving global neurosurgery, but here at home, he's really been a pioneer in minimally invasive spinal surgery. His work both as a clinician and a researcher and really as an educator has earned him innumerable awards and nearly 200 publications. Today, he will be distilling his wealth of knowledge into 5 guiding principles about minimally invasive spinal surgery. So Dr. Härtl, it is a pleasure to have you once again.
Rupert, thank you so much for the kind introduction. And I'll talk to you today about minimally invasive spinal surgery. And these are my disclosures. I'm going to talk to you about target, which is patient selection, technology, techniques, teaching and training, and maybe also a little bit about research. But first, I would like to start by proposing a definition for minimally invasive spinal surgery. And we came up with that definition as part of work that we did on a curriculum for minimally invasive spinal surgery that was just published. And we felt that minimally invasive spinal surgery is a suite of technology-dependent techniques and procedures that reduces local operative tissue damage and systemic surgical stress, enabling earlier return to function while striving for better outcomes than traditional techniques. Now, this is a working definition, and there's no class 1 evidence yet that we're really there, but that's really where we're trying to get to. And I think we've achieved a lot over the years, and I'll talk about that over the course of this meeting. I also want to point out that minimally invasive surgery, spinal surgery, is really something that has defined our department even before I came here. You know, we had a number of spine surgeons here who really had an amazing, fantastic reputation for minimally invasive spinal surgery, and we've continued that, and now we have a great group with a diverse spectrum of MIS surgical techniques. You know, with Eric Elowitz, who does endoscopy, Ali Bash, who does a lot of tumor and pediatric surgery using less invasive spinal surgeries. We've got Michael Verk and Kai Fu, who really tackled MIS for deformity surgery. And then we've got the Spine Center that offers interdisciplinary approaches using a lot of less invasive procedures as well. So MIS surgery really defines us as a group here at Weill Cornell. And if you look at our website, and if you try to understand how we're taking care of patients in our spine center, it is interdisciplinary. Our treatment approach always begins with the least invasive option depending on the severity of your symptoms. And if surgery is recommended, we will always offer the least invasive surgical option that is safe, effective, and has excellent long-term outcomes. So that's the pledge to our patients. And that just goes back to show you how important MIS surgery really is for what we do here in the spinal group. And we came up with the 5 T's in an attempt to figure out, well, what really defines MIS surgery, and what can we tell young trainees and fellows and residents who want to become good at MIS surgery, how can they get there? The first T is the one that we rarely talk about, is target, is patient selection. How do you pick the right operation for the right patient? It's probably one of the most challenging things in all of spinal surgery, not only MIS, of course. The second T is tools and technologies, and that refers to all the things that we always hear at meetings where we go to a company-sponsored spine course. We hear about the latest pedicle screws, expandable cages, navigation, and I'm not going to talk about that a lot during this presentation. Instead, I really want to focus on surgical technique, especially microsurgical surgical techniques, and how they really enable us to perform spinal surgery with less invasive techniques. And there are three surgical principles or surgical skills that show up over and over again when you try to perform MIS surgery. The first one is really the attempt to perform a unilateral approach for bilateral spinal decompression, and we'll talk about that much more. By doing that, you preserve stability, so you avoid removing part of the spine that would otherwise be responsible for preserving spinal stability, and therefore you can do decompression procedures in patients where if you did an open operation, you would have to do a fusion. And then finally, indirect decompression, which refers to putting in cages anteriorly or laterally into the spine to achieve indirect decompression of spinal structures and also to achieve a certain amount of deformity correction. I'm not going to talk about that a lot during this presentation. I'll focus a little bit more on teaching and training later on, and testing and research. Now, if you look at where MIS really fits the spectrum of minimally invasive spinal surgery, what is really the role if you look at spinal surgery as a global entity? If you plot the complexity of spinal surgery, starting with the least complex pathology and operation, which is a lumbar disc herniation, to the most complex, which is complex spinal deformity, and if you plot that against invasiveness, you will see that with open traditional surgery, whether you do a lumbar disc herniation with open surgery or the endoscope or the tube, there's no huge difference. Those patients do very well. They go home the same day. But then with open surgery, that curve steepens very, very quickly. Already when you come to lumbar stenosis, if you do an open lumbar laminectomy, it's a pretty invasive operation. There's an infection risk, CSF leak risk, and so forth. And then obviously as you come to fusion surgeries with open traditional surgery, those are fairly invasive. There's a lot of blood loss, patients stay in the hospital a long time. Now, MIS surgery dampens that curve. You'll see here with the low complex pathology, there's no huge difference between traditional surgery and MIS, but then in the mid-zone, that's really where the difference is. And then if you come to complex deformities, again, there's no big difference whether you do it with open or with MIS surgery. So I would propose then the MIS benefit zone is really the pathologies that comprise lumbar stenosis and other pathologies that would require 1, 2, 3, maybe 4 level fusion surgery. So mild deformities, spondylolisthesis, those are the procedures that are being done very, very successfully and very effectively with MIS surgery, and that's the MIS benefit zone. Now, if you look at the whole spectrum of spinal surgery, we do about 1.2 million spinal surgeries in North America. Now, this year it's probably going to be half that because of the crisis. But if you look at the 1.2 million surgeries, we think that about 75% of those can be done partially, completely with MIS technology. So it's a huge number. Target. I want to say a few words about surgical decision-making, because it is important to understand that when we talk about MIS. The key about MIS surgery is the accurate diagnosis, and that's why it's so important to work with an interdisciplinary group, because in order to figure out whether a patient is symptomatic from that L5 nerve root being compressed in the lateral recess versus the mild lumbar stenosis or the spondylolisthesis, that requires this, history taking, careful neurological examination that you can do, but you may need injections, target injections, you may need electrophysiology. So you need to work with a group of individuals who help you make an accurate diagnosis. And once you have an accurate diagnosis, you know that that patient is really symptomatic from that L5 nerve root and not from the mild lumbar stenosis or a little bit of spondylolisthesis. Then you can do a focal MIS decompression. So it prevents overtreatment and it allows a very, very targeted treatment of a particular spinal pathology. Now that's number one, but then you have to understand the natural history of the disease. If that patient has at L4-5 a pars defect and instability, then you'll have to do a fusion because the natural history of that disease is such that those are unstable problems that you should take into consideration. On the other hand, if that patient has a stable spondylolisthesis with a collapsed disc space, you may be able to just do a decompression. You don't have to do a fusion because the natural history of that is totally different. And then finally, the impact of your operation on the disease. If you do a tubular decompression, you can decompress the patients without causing instability. If you do an open wide laminectomy and you remove part of the facets, you'll have to do a fusion possibly, because that may the procedure itself may destabilize the patient. So these are all, and you could spend a whole day talking about this, and maybe we should at some point, but it's really the art and the science of coming up with an accurate diagnosis and then with a good treatment option and treatment strategy for this patient. I just want to give you this example. This is a patient who came from Europe with these x-rays. So it's a lady who had a L4-5 fusion done, totally minimally invasive, 2 tiny little incisions, beautiful radiological outcome. But the patient still had, a year after the operation, she had the same symptoms, namely neurogenic claudication, which she had before surgery. So we got an MRI scan, and the patient had lumbar spinal stenosis. So this surgeon, who's a very famous MIS surgeon in Europe, did a beautiful fusion operation. It was the wrong operation for the wrong pathology. They missed the fact that she had neurogenic claudication. All she needed was a tubular decompression, which is what we did here, and she did very, very well. This just goes to tell you that we're really distracted as MIS surgeons sometimes. We're looking at technology as pedicle screws, at cages, and we totally forget about the target, meaning the decision-making process. So you got to take that into consideration. The second T is tools and technology. So the tubular retractors, the microscope, navigation, the implants, the pedicle screws, the expandable cages, the drill. I'm not going to talk about that a lot here, but that's something that you pick up if you go to all the regular courses that are out there. And obviously there's a lot of literature about this. No lasers, by the way. Not for us. Techniques. Now, the 3 technique principles that always come up in MIS are the contralateral decompression, so unilateral approach for bilateral decompression, the fact that by doing that, you minimize iatrogenic instability, and then finally, the interbody fusion for indirect decompression and deformity correction. Those are the 3 technique principles that come up and that you can't really read about in books. You really have to do this in a cadaver or over your residency or with surgical simulation, as we'll talk about later. And I want to focus especially on the first 2 principles, which is the fact that you can perform a bilateral decompression of the spine and the contralateral foraminotomy through a unilateral minimally invasive approach. Minimally invasive spinal decompression can reduce iatrogenic instability and reduce the need for instrumentation and fusion surgery. Now, this is something that was described really in open surgery in the 1990s. There's a fantastic book by John McCullough, who was an orthopedic surgeon, and Paul Young, who is a neurosurgeon in St. Louis. And they talked about microsurgical techniques for spinal pathologies. And they described already in the 1990s, as you can see here, that you can do it, and they did that with open surgery. You can do that with open surgery as well. A unilateral approach for bilateral decompression and contralateral foraminotomy. It was then really Rick Fessler, Kevin Foley, who introduced tubular retractors in North America and around the same time. And then it was Sylvain Palmer, who's a private practice neurosurgeon in California, who used tubular decompression and the idea of using a unilateral approach for bilateral decompression for lumbar spinal stenosis. And the first publication on that, to my knowledge, was in 2002. And then when I came here after my fellowship, I really started doing more and more tubular surgery, using it especially for lumbar spinal stenosis because it seemed to really make a lot of sense. Now, this is an example of a patient with neurogenic claudication, grade 1 spondylolisthesis, severe lumbar spinal stenosis, as you can see here. And if you look at the guidelines that were published in the beginning of the 2000s until the mid-2005 and 7 and 8, the guidelines really told you that you had to do a fusion. This patient has spondylolisthesis, lumbar stenosis, you have to do a fusion. And this was published in the neurosurgical literature and also in the orthopedic literature. Now, the question again is that really necessary? And we've had these debates here at our M&M conferences and our case conferences for decades at Cornell. And we've always been very, very forward thinking in terms of not having to do a fusion in these patients as long as these patients have a stable disease that's not, as long as they don't have unstable spondylolisthesis. And you can test it by getting flexion extension films and by looking at the type of pain do they have. Do they have mechanical back pain, or is it really more neurogenic claudication, which is very clear once you talk to these patients and examine them. So in this particular case, so this patient had really neurogenic claudication. There was no mechanical back pain. The natural history of grade 1 spondy without a pars defect overall is very benign. And the likely impact of surgery, if you do this with the endoscope or with tube, is minimal. You don't cause any iatrogenic instability. So instead of doing a big open laminectomy with blood loss, CSF leak risk, and all these things, we do a tubular, minimally invasive tubular decompression. We undercut the spinous process and get a beautiful decompression in this patient. This patient goes home the same day or the next morning. And overall now they do really, really well. We had one of our fellows, Carsten Schöller, he wrote this up. He looked at the literature looking at patients with grade 1 spondylolisthesis with either an open traditional laminectomy or a minimally invasive laminectomy over the top tubular or specular decompression. And the literature clearly shows that if you have an open laminectomy, about 13% of those patients go on at some point needing a fusion versus only 3.3% of those patients needing a fusion who had a minimally invasive decompression. Patient satisfaction is greater if you do a minimally invasive decompression in these patients. And there's less slip progression after a tubular or specular decompression, and patients in general are happier with that type of surgery. So there's a lot of literature now showing that, and I think the tendency is in the surgical community to really accept this as a standard of care. Now, again, we're talking about contralateral decompression and the fact that we can minimize iatrogenic instability by doing that. How do we do that procedure? We use bayoneted instruments. These are in terms of the technical setup, it's really a low resource technical setup. We've done this in Tanzania and Pakistan. The infection risk is less, bleeding risk is less, and patients, like I said, in general do really, really well. These are just some drawings that explain the step-by-step surgical techniques. This is a patient with lumbar spinal stenosis at L4-5. We're choosing a right-sided approach. We place the tubular retractor. We get an X-ray to confirm placement of the tube, correct placement of the tube, of course. And then this is what you see under the microscope. You can also do this with loupes, but the microscope is obviously nicer. You see the inferior edge of the L4 lamina. You see the base of the spinous process here, the ligamentum flavum. And then we start drilling, and then we expose the insertion of the ligamentum flavum cranially with a ball tip. You lift up the ligamentum flavum. And then the question is always, how do you get contralateral? How can you make sure that you really get an adequate contralateral decompression? And the key here is to rotate the table away and to angle the tubular retractor. And you leave the contralateral ligamentum flavum, you leave that intact, and you drill behind the ligamentum flavum into the lamina. The concern is always that you may destabilize the spine, and that's the nice thing about using navigation during your learning curve. You can exactly see where you're drilling, because surgeons, they always think that they're getting into the facet joint here, but they're not. You're actually undercutting the contralateral lamina, and you're far away from the facet joint or from the pars, and you can drill very aggressively as long as you have the ligamentum flavum here that protects the dura. And you got to drill with one hand. You got to be comfortable using your drill with one hand, and you protect the dura with the suction, of course. There's even a movie, Over the Top Decompression. I just watched it a week ago with my kids. So we call it over the top decompression, or ULBD, unilateral laminotomy for bilateral decompression. And then, as you can see here, once you've done your decompression, you can do a contralateral foraminotomy. So you can decompress that nerve, or if there's a soft discronation, you can remove that. You can decompress the contralateral traversing nerve. In this case, that would be the L5 nerve. You can decompress the ipsilateral traversing nerve, which is the ipsilateral L5 nerve. What you cannot decompress is the ipsilateral exiting nerve. So that's why you have to make sure that goes into preoperative planning, the target. If the goal of the operation is to decompress the ipsilateral exiting nerve, then you got to come from the other side, or we got to choose some other type of surgical approach. But those three nerves in the fecal sac, you can beautifully decompress. And this is a video now showing coming from the right side, over the top, looking over the top, the dura, that's the ligamentum flavum. Now we separate the dura from the ligamentum flavum here. You can see the ligament and the contralateral lamina here. And how do we get now, and what the residents and the fellows, and when we teach this in courses all over the place, what most surgeons never understand, or they're very uncomfortable with, is drilling, the over-the-top drilling. So for us neurosurgeons, that is very natural. We're not really that worried about. But if you teach this, what most surgeons are worried about is really the drilling with the dura being exposed and looking over the top. So the way you do that is you leave the ligamentum flavum contralateral intact, and you drill a trough into the lamina here. So the ligamentum flavum on the other side protects the drill. The sucker obviously protects the drill. And that's how you can then you bring in your Carricin rongeurs, you remove the ligamentum flavum, and you get a beautiful, as you can see, a really nice, beautiful contralateral decompression. As a matter of fact, the decompression contralateral sometimes is even nicer than the ipsilateral decompression. And so that's the key. That's the key how to do this operation. You've got to tilt the table away. You've got to undercut the spinous process, undercut the ligament, undercut the contralateral lamina, and then you get out into the foramen and can do a beautiful foraminotomy. We do that in the cervical spine now as well. This is an elderly patient who was myelopathic. Instead of doing a multi-level open laminectomy and fusion, we just did a minimally invasive tubular over-the-top decompression at C4-5, which was really the level where that patient was symptomatic. And we wrote that up. We just published that in a video. So it really expands the use of MIS surgery also into the cervical spine, not only for cervical foraminotomies, which is something that we've done obviously for a long time, but also for lumbar spinal stenosis. And we've done 1 and 2 level lumbar stenosis, cervical stenosis cases that way. But you use a slalom technique. You come from different sides. So where do we use now decompression instead of fusion surgery? Tubular decompression in lumbar spinal stenosis patients who have a stable spondylolisthesis. So again, as long as they don't have any mechanical back pain and no significant instability on flexion extension films. If somebody has a foraminal soft disc herniation, you can get in there with the endoscope from the ipsilateral side, or you go over the top contralateral and can decompress the foraminal disc herniation that way, or most synovial cysts as well. We do an over-the-top decompression from a contralateral approach. So what I translated MIS, instead of minimally invasive spinal surgery, I think we can say it's minimal and measured instrumentation surgery. That's really what it translates to. What do you do with multi-level lumbar spinal stenosis? Now, Michael Meyer from Munich published that here. So patients who have 3 or 4 level lumbar spinal stenosis, what we do is we do a slalom technique. We make 1 incision per level, and we alternate right and left to make sure that we're not taking too much of the facet joint on one side only. So we alternate our approaches, and we've done that here very successfully over many years and published that as well. And we finally then, Rick Fessler and Kevin Foley really pioneered a lot of this, but they never really wrote up their experience. So we published a paper a few years ago where we tried to summarize all the little tips and tricks on how to do tubular decompression surgery, how to use the drill under the microscope through a tube, what type of tube to use, what diameter tube, how do you treat levels higher up differently from levels lower down, how do you treat synovial cysts through a tubular retractor, how do you fix CSF leaks. So we wrote all that up, and there was a lot of interest in this in the community, which really leads me to the next part of the talk. But some tricks here for some of the younger, for the residents and for the fellows. So for foraminal stenosis with radiculopathy, we typically will use a contralateral approach in the lumbar spine. For central stenosis with neurogenic claudication, for a right-handed surgeon, it's more advantageous to use a right-sided approach because the ligamentum flavum is very thick, and most of this operation really entails removal of the ligamentum flavum, which if you come in from the right side, you primarily do with your right hand, so there's a lower risk of a spinal fluid leak. If you come in from the right side and you're a right-handed surgeon. Lateral recess stenosis, if it's higher up in the lumbar spine, we go contralateral to avoid an injury to the pars. If it's lower down, L4-5, L5S1, will come in ipsilateral. And then obviously unilateral disc herniation, we use an ipsilateral approach. And synovial cysts, we use a contralateral approach. And it always comes down to the same technique principles. Once we place the tubular retractor and we see the base of the spinous process here and the lamina, we'll always start drilling at exactly that point, because the goal of the operation initially is to expose ligamentum flavum. Once you see the ligamentum flavum here, you're golden. You know where you are, you know where's medial, where's lateral. Then if you do a microdiscectomy, we expand the laminotomy laterally. If we do an over-the-top decompression for lumbar spinal stenosis, the goal is to expose the insertion of the ligamentum flavum, so we go cranially. If we do an MIS TLIF fusion operation, we drill through the pars 45 degrees to harvest the facet joint. But we always start drilling at exactly that same point. Another trick or another principle really is when you use the drill through a tubular retractor, obviously always lean your drill against the rim of the tube. That'll allow you to stabilize your instrument and to drill with one hand, and then you have your other hand for the tubular retractor. So, and then we started teaching this in courses, and we came across this surgical simulation model, which is essentially a lumbar spine model that's being done by a company. Now, there are a bunch of different companies out there who do these, but it has bone, it has ligamentum flavum, it has dura, it has CSF, and the quality of the bone when you drill is fantastic. It feels like totally realistic bone. It's haptic. It's really it's very accurate. And we started teaching the procedure to surgeons worldwide, and we tried to figure out, well, what's the best way of really teaching the operation, the ULBD, the unilateral approach for bilateral decompression, and is there a way of teaching it that we can use to really standardize the operation? So that's how we came up with the project that we just published. There was an attempt to define the ULBD procedure in a number of phases and steps in such a way that we can actually teach it with a surgical simulation model worldwide to surgeons and to residents and trainees and so forth. Now, we had already developed steps for the paper that I just showed you, but we really want to make sure that we have consensus among surgeons so we can roll this out at spine courses all over the place. So what we did is we got 3 experienced spine surgeons together. It's myself, an orthopedic surgeon from Munich, and Kevin Foley, and 1 educational expert. This was done through the AO. And we came up with a consensus on the different phases and steps of this procedure. So each expert performed 2 procedures on a simulator while being scored by the other surgeons. So we all came together. We did that during one of our MIS courses here in December a few years ago. We recorded videos, and then we critiqued each other's videos, which was quite fascinating. But what was also fascinating was that even though we had never worked together, and I never trained with Kevin Foley, we really ended up doing the operation almost in an identical way. So, which was quite reassuring and which was really interesting to see. There were details in terms of how we did things, but overall we did it in a very similar way. And then once we had reached an agreement amongst those 3 surgeons, we contacted 26 spine surgeons from 14 countries and performed a modified Delphi panel to reach consensus on how this operation should be done or could be done. And this is just from one of those sessions that we had. This is Kevin Foley doing the over-the-top decompression for lumbar stenosis, and he likes doing this operation sitting down, which is one of those little differences between surgeons' preference. But other than that, we did it in a very, very similar way. So we defined 6 phases and 44 steps for this operation. 21 errors, and 17 of those errors were sentinel errors, which are errors that are severe, which may really change the course of the operation, such as a CSF leak, or if you drill into the pars and cause instability. And this is just an example of some of those phases and steps that we came up with. This is the complete ipsilateral decompression. So we have all these little steps that we're looking at: how to drill the bone, how to remove it with the carosum rongeurs, to lift up the ligamentum flavum. And then we defined errors for each phase: injury to the pars, CSF leak, and so forth. And using that surgical simulation model, believe it or not, you can get a CSF leak. We had a few surgeons, mainly orthopedic surgeons, who got CSF leaks, but you can do that and you can quantify it, and that's what we did. And then we submitted it to our Delphi panel, and the Delphi panel deleted 2 steps and modified 11 of our 44 steps. And at the end of the day, we came up with a fairly well-outlined procedure for the unilateral laminotomy for bilateral decompression that we use now for training courses, primarily through the AO. Now, the next study that we started, and this is preliminary now, we wanted to see if by using these metrics, we can help trainees in their learning curve for the procedure. So we got funding to get us those surgical simulation models. We had 6 fellows and residents in Europe, 6 fellows and residents here in New York, and we had them all do 3 procedures in a row. We showed them first how to do it. We went through the steps. Then we had them do the operation 3 times in a row. Each time we discussed the mistakes, and then we looked at the results in terms of the errors, the timing. We videotaped all procedures, and we are still in the process of analyzing the videotapes, but I can show you some of the results here. You can see it's a mixed group of residents. We had orthopedic residents and neurosurgical fellows and residents at different times of their career. You can see, if you summarize the surgical timing, that this is the first operation they did, the second operation, the third operation. As you would expect, the surgical timing gets better, so they don't take as long to perform the operation. We also looked at the errors. And again, the errors are, for example, using the wrong size carosine to remove the ligamentum flavum, too much pressure on the nerve root, drilling into the pars, getting a CSF leak. And if you look at the number of errors from procedure 1 to procedure 3 in Munich and in New York, as you would expect, obviously, the number of errors dropped very nicely. What we also did was we did a gap analysis, which we haven't completed yet, and we did a video analysis. So we videotaped all these procedures, and we had 3 independent spine surgeons grade those videos in terms of surgical expertise, knowledge of the instruments, instrument handling, respect for tissue, time and motion, knowledge of specific procedure, and so forth. And so this is just an example of one of those surgeons being evaluated. Again, this is upcoming, but obviously, hopefully what we'll see is that the surgical expertise improves over time. Now, finally, I want to talk to you about a curriculum. Now, this was all done for the ULBD procedure, but we also started working on a curriculum that allows us to be used during a spine course to teach surgeons the basics of MIS, but also more advanced MIS techniques. So the curriculum was done together with the AO. We put together a panel of 8 spine surgeons, 8 global spine surgeons, a mix of orthopedic neurosurgeons from all regions in the world. Richard Asaka is from France, Mohamed Asus from Jordan, our beloved Christoph Hofstetter from Seattle, Luke Kim from Korea, who's really world-renowned expert in endoscopic surgery, Avelino Parajon from Spain, Nestor from South America, Paul Taylor from Australia. These are all surgeons who are very well versed, done a lot of teaching over the years. So we worked on a curriculum, and we decided to address the very, very basics first. So how to use a microscope, how to use an endoscope, how to use a burr through the endoscope, how to use a burr through the microscope, how to incorporate navigation into spinal surgery, how do you manage a dural tear, bleeding control, how do you control bleeding? We did cases through the tube in Tanzania, and they don't have flow seal, they don't have any hemostatic agents. Now, this simple operation suddenly becomes a huge challenge if we do it in an environment where you can't really get good bleeding control. And then radiation reduction. So we covered those 8 general skills, and then we also tackled 4 tubular procedures. So that's the ULBD, the tubular operation for discectomy and so forth, the cervical foraminotomy for tubes, 3 endoscopic procedures, and 2 instrumentation procedures, percutaneous pedicle screws and an MIS TLIF. So that first part of the curriculum has now been finished. It's rolled out in AO courses worldwide. We're discussing with NAS right now that they will adopt this curriculum, and we're also discussing expanding the curriculum to more complex MIS procedures such as MIS XLIF, LLIF, OLIF, and so forth. And these are just some examples from the curriculum material that's available. Obviously, there are PowerPoints, how to use a microscope. We worked on handouts, PDFs, how to do a MIS decompression through a tubular retractor. This is now endoscopic. We have videos for endoscopic surgery with PowerPoints. And then we have MIS TLIF procedures. For example, here we also have on the iPhone, we have there's a software that we can use to show the steps. And the way that we do it with courses is really, it's the reverse, it's a flipped classroom principles where we make this material, somebody signs on for a course and they get this material before the course and they're supposed to work through a lot of this material on their own. And then once they go to the course or they have the virtual course, what we do is really more practical teaching. So it's the reverse classroom or the flipped classroom principle. And that seems to work very nicely. The curriculum assets available, again, are the teaching videos, the brochure, the surgical manuals, and we're expanding this now to more complex spinal procedures. Now, at the very end, again, I just want to finish up by summarizing. What I was trying to convey is really the fact that I think at Cornell here, we have a great position when it comes to performing MIS, to really using MIS for the benefit of our patients, not only as a surgical group, but really as a comprehensive spine group. We have a long tradition. We've done, each and one of us has their own MIS surgical niche that they're using, which works out very, very nicely for the group. I think patient selection, procedure selection is one of the most important things, and we certainly haven't done a good enough job really defining that in spine. And that's one of my interests I would like to look into more in the future, tools and technology. We know about that. The surgical techniques, we talked about that. So I'm using the microscope, using the endoscope, doing the over-the-top decompression, and teaching and training. We focused a lot on that. Testing research I didn't talk a lot about, but obviously what this also entails is collecting data and then using that data to feed back into MIS surgery, into the curriculum to make that better. But for me, what MIS really means at the end of the day is really minimal and measured instrumentation surgery. And that's how we differentiate ourselves from other centers nationally and internationally. By using MIS surgery, we can avoid fusion surgery. Patients don't like fusion surgery. And spine surgeons act like they don't know that sometimes, but it is really true. And MIS really gives us an opportunity to harness that and to make sure that we treat these patients ethically and correctly. So thank you very much for your attention. Thanks for the support from the other spine guys, without whom I would never be able to do any of this work, of course, and also the Spine Center and each of you as well. Thank you.
Great, thank you so much. That was an amazing overview. We'll open it up to questions if anyone has any.
Yeah, Roger, it's Mike. I have a question. First of all, it's great. I mean, we've known each other longer than anybody else on this call, as you remember when we sat down for a drink when you were coming to us from Allegheny. So it's really fantastic to watch the evolution of all of this and how this has really expanded minimally invasive surgery between skull base and spine and everything, the reputation of this institution. So it was really terrific. My specific question is, you talked a lot about the importance of ligamentum flavum in terms of the way you do these unilateral approaches to a bilateral decompression. And you had shown one example of the cervical spine, even though you talked mostly about lumbar spine. you know, in the cervical spine, a lot of times you open up and there's not a whole lot of ligamentum flavum there, right? I mean, I know when I do spinal stimulators, and those people usually don't have nearly the compression that you have, otherwise I wouldn't be operating on them.
Right.
And despite that, I open up and, you know, probably a third of the time, there's like no ligamentum flavum there. So when you have that situation with the tube, do you just take extra time and be extra careful, or do you back out and open it up?
Right. Well, that's a good question. You gotta really look at the films very carefully. There are patients who have ligamentous hypertrophy in the cervical spine, and you can see that on the MRI scan. So it is important if you use this in the neck. Obviously, you got to be very careful. It's not like in the lumbar spine where you can just push down on the dura. So I use monitoring in those. You know, I did a lot of these cases initially with navigation because I wanted to make sure I knew exactly where I was. And you got to look at the MRI scan. If there's ligamentous hypertrophy and the patient is not kyphotic at that level, that's the other thing. If that patient is leaning forward at that level, you're not going to get a good decompression if you just decompress the back. So the patient has to have at least a straight spine at that level, or a little bit of lordosis plus ligamentous hypertrophy, and then you can get a really nice decompression. And that operation is much faster than in the lumbar spine because it's very focal. The hypertrophy, it's not like in the lumbar spine we have like tons of ligamentum flavum. It is very limited, but if you decompress it correctly, you can have a really nice result. But those are highly selected patients. I mean,
but I'm asking, what about the opposite? What if you have stenosis and you open up on one side and you open up bone and immediately see dura, and you don't have that layer of ligamentum flavum to protect you as you go to the other side, because you made a big deal about that. So what I'm saying is, at that point, do you just finish the operation and just take extra time and hope you don't have a problem, or do you back out and open it up?
No, you only do it in patients who have ligament. You can see that on the MRI scan beforehand. You can see the ligamentum flavum. If they don't have ligamentous,
if you can't clearly see it on the MRI, then you won't do it.
Yeah, no, then I don't do it. No, you can only do it. The way that you get decompression is by removal of ligamentum flavum. If that's not the cause for the lumbar stenosis, like if they have congenital lumbar stenosis and no ligamentous hypertrophy, I wouldn't do it because there's no safety zone between the dura and the bone. You're right. You know.
Roger, I have a question. First of all, it's a great talk, and you know, it's remarkable the number of parallels between minimally invasive brain and spine surgery. And when you're using endoscopes and you're using tubes, you face a lot of the similar constraints, and we end up arriving at a lot of the same conclusions regarding, cross court and how important where you're starting is to where you're going to end up if you're decompressing the optic nerve and you're opening the canal, and what's going to be in your way when you can't see as much, and patient selection being incredibly important to be successful. And one of the problems is if you're trying to do a case minimally invasively that shouldn't be done that way, and you're selecting the wrong case, your results are going to be poor, and then you're going to think it doesn't work, but it's because you're not using, you're not choosing the right person to do the operation on. One thing I wanted to ask you, though, is that this concept of really formalizing the steps and having buy-in among experts is something that maybe is less the case in skull-based surgery. And, there sort of are different schools of thought as to how to do these surgeries. And there's so many different steps that you have to go through. Do you feel in spine that this is sort of one school of thought for MIS, and have all the experts, do you think they'll buy into this same way of doing the procedures, or are there different schools of thought and different experts who do it slightly differently, who will say, yeah, that's great, that works for you, Roger. I do it differently. I'm not going to change the way I do it to follow these steps. I follow a different set of steps. And then you may have a couple different parallel schools of thought as to what the correct steps are. And have you encountered that, and how widely accepted is this?
Yeah, Ted, first of all, I wanted to say I was watching your course, your Mark's course, and there was you had a presentation about using tubular retractors, and that was just exactly the same thing. I was watching that, I said, oh my God, we have our offices right next door to each other. And he's doing exactly the same thing in a way in the brain that we do in the spine, and it is quite amazing. And
by the way, I caught you spying. I caught you spying through the door. So
No, it is, but you know, the reason we started with really a very, we started with techniques, basic techniques, and then a very simple, in a way, simple operation. And I was amazed, exactly for the same reason that you mentioned. I was amazed that first of all, that we found consensus amongst the 3 surgeons in the beginning, and then the 26 surgeons but then, you know, who knows, you know, I mean, they eventually agreed. I don't know really if they really do it in their practice that way. But we picked a relatively straightforward operation. Now, if you go to more, and that's why we haven't gone to complex fusion operations, because I know exactly that's going to happen. You know, once you get to operations in the spine that entail putting in screws and cages, and then you go from the back, from the side, everybody does that. It's going to be very, very difficult. This was really an attempt to pick an operation that is relatively straightforward, but really allows surgeons to hone their skills. You know, how to use a microscope, how to use a drill, how do you look at the spinal anatomy without really stirring up too much controversy. But this is something you can teach to the residents and to surgeons all over the place. And the way that we came up with a protocol that the surgeons agreed upon is going to help us tremendously in teaching this operation. But we know that the next, you know, even an MIS TLIF is going to be very difficult to really standardize that way. And then when you come like to 2, 3, 4 level fusion operations, it's probably going to be impossible. But the way I look at it is really, this is a simple operation, and the goal is to really to treat the basics of MIS surgery. And for that purpose, I think it's the right thing. Now, for your field, you know, I don't know what would be the equivalent operation. You know, I don't know. You know, maybe a biopsy or something. You know,
probably a small pituitary adenoma or something.
Yeah. So, but the whole idea here was we're trying to pick simple things, basic things. However, where we knew that there was a tremendous amount of lack in surgeon skills. If, you know, because we deal with orthopedic surgeons who've never used a microscope, who've never used a drill, and then you got to try to teach them how to use a drill under the microscope. And this operation is perfect for that.
Yeah. Thank you.
Yeah.
Yeah, Roger. Hi, it's Eric Elowitz. It was a great talk, really great overview. You know, in addition to MIS, you've also done award-winning work on potential biologic approaches to the spine. I know that's a whole separate topic, but how do you see biologic approaches fitting in with the MIS in the future?
Yeah, I mean, that's a great question, and the biologics are the ultimate MIS solution, of course. The question is, does it really work, and when is it gonna, you know, what are really the right indications? So I think we need to do more work on really showing the efficacy of biologics. Once we show that it actually really works, I think then MIS is going to be, they're going to fit together perfectly, you know, because of the approach. You could, for example, I mean, if we can show that, you know, injecting, you know, stem cells into the disc actually really helps regenerate the disc, we could do an endoscopic discectomy and at the same time treat the adjacent levels that look a little bit degenerated. The problem is we just don't know for sure that it really works yet. But once we, and so I think that it's not as much as trying to how to incorporate it at this point. It's really trying to show the efficacy of the biologics, and that's what we're struggling with. But I think eventually, hopefully, if we can show that, it's going to be a perfect marriage between the MIS technology techniques and the biologics.
Great, thanks.
Great, thank you, everyone.
And I want to thank Phil for pushing and always encouraging me and others over the last 20 years or so. Without his support and his encouragement, none of this would have really happened. So I really want to thank him for that. All right.
Great. Journal Club in 2 to 3 minutes. Everyone get a cup of coffee, and then we'll meet on a separate Zoom. Thanks.
Okay, great. Thank you, everyone. So no grunt rounds next Monday. We'll pick up back up on June 1st.
Yeah, and just to remind everybody, on well, June 1st is going to be M&M, right?
M&M.
So
Mhm.
at the next grand rounds, which would be June 8th, that's when we're going to restart 7 a.m. case conference now that as of today, all of our residents are finally fully back from redeployment and the written exam is over as of Friday. So, we'll restart at the next grand rounds, which I guess is in 2 weeks. Okay.
Yep, so the second Monday of every month, we'll be doing case conference followed by journal club. So that'll be a part of the curriculum. And then we'll have our grand rounds with our visiting professor on June 15th.
Right. Okay.
Okay, great. Thank you, everyone.
Bye.